Hi, my name is Sheema Hussaini. I'm a nutrition and dietetics intern at Benedictine University. I'm studying to be a registered dietitian, and this rotation is part of the program. As nurses, you must have worked with a registered dietitian. I'm going to refer to them as RDs from now on in a hospital. The role of an RD in a hospital setting is to provide medical nutrition therapy for the patients. In a long-term care facility, they work with the interdisciplinary team of nursing staff, speech-language pathologists, and doctors to improve the quality of life for the residents. They are also involved in food preparation, menu planning to adhere to the individual needs of the patients based on the disease state and their personal preferences. So the role of an RD is from kitchen to the bedside. So in order to provide a complete nutritional care to the patients, we have to look at all their micronutrients as well as the macronutrient intakes for able to provide them with a well-balanced diet. And these can be obtained by consuming different food groups. Some of the ones that are on the slide over here are carbohydrates that are made up of grains, cereals, pastas, fats that are part of the protein and fruits, and you can also find some fats in the vegetables, vitamins that are obtained from fruits and vegetables, and all the different food groups. Protein are found in grain and cereals, legumes, meat, poultry, beef, fish, eggs, nuts. So in order to get a well-balanced meal, a patient needs to be taking in all these food groups. But as people get older, it can get harder for them to get all the required nutrients, and thus can lead to deficiencies in the patients. So the role of an RD is to make meal plans and provide nutritional education and counseling to the patients so that they can get all these required nutrients and be able to heal themselves and stay healthy. So this is the picture of a whole plate from the FDA, Food and Drug Administration's healthy eating website called myplate.gov. So based on the dietary recommendations, each person, especially the elderly residents, should take 45 to 65% of their total calories from carbohydrates that are grains, 20 to 35% from fats, and the recommendation is to have less than 10% of saturated fats, 10% of calories from saturated fats. Protein intake is recommended at 15 to 25%, and fluid intake of roughly about 1.5 liters of fluid per day. But this fluid intake varies in the older population from anywhere from between 25 to 30 milliliters of water per kg of their weight per day. Like for example, a 65-year-old patient who weighs 125 pounds will have a fluid need of 1.7 liters per day. And a patient with the same weight but who is 75 years old will need 1.4 liters per day. So this range varies significantly across the age and also based on the health condition or the disease states. As we age, we go through many physiological and anatomical changes. Some of them are more visible, like a person becoming frail, muscle loss, loss of height, and some of them are more subtle. All these changes can affect their dietary intake and their nutritional needs. Now we will look at the effect of anatomical and physiological changes on the digestive system of the elderly patients. According to statistics, 30% of the adults lose their teeth or start losing their teeth after the age of 65. This causes them to have trouble chewing and swallowing the food. Some elderly may have loose tooth or poor fitting dentures, or which affects the intake of food. As they age, the digestive juices enzymes are also reduced and can slow down the peristalsis, which is the movement of food through the digestive tract. This also causes the changes in appetite due to the feeling of fullness, bloating, and they can have lack of appetite. Some elderly might be living alone, which also affects their eating patterns. There's also a change in the nutrient absorption, digestion, and metabolism because of the weakening of the gut lining. Alteration and reduced function of the villi at the brush borderline of the gut lining can also alter the absorption of nutrients. This can cause deficiencies in them. Sometimes elderly also suffer from nausea, vomiting, diarrhea, which can further reduce appetite because of GI issues. In 2000, Surgeon General declared poor oral health as a silent epidemic among the older population. Some of the other factors that can affect the nutrient intake in the elderly population is the visual changes, their hearing loss, changes in taste, like the number of taste buds decreases as they age, and also the sensitivity of the taste buds is reduced as a normal part of aging. And there also the sensitivity to the taste is reduced because of medications that they are taking. There's also a decrease in the production of saliva, which makes it harder for them to chew and swallow food. Changes in smell because of the reduced mucosa in the nose. There's also changes in the nerve endings, which make it less perceptible to sensory inputs. So what does it all mean for the nutritional status of the elderly patient? It's going to decrease the sense of pleasure while eating because smelling, tasting, seeing is an important part of promoting appetite, desire to eat more and nutritious food, and this can cause like unintended weight loss in the adult population. Along with the anatomical and physiological changes in the elderly population, another factor that impacts their nutritional status significantly, I think, is the occurrence of many chronic diseases and health conditions. As we age, we become more prone to developing a chronic disease or developing multiple conquering diseases like in a metabolic syndrome with hypertension, congestive heart failure, obesity, diabetes, coronary vascular diseases. Patients may be placed on a low sodium diet for hypertension, low fat, high fiber diet for cardiovascular diseases, carb control diet for diabetes, hypocaloric diet for obesity. So this makes it challenging to meet the nutritional needs and can significantly limit food choices, thereby affecting the intake of food in the elderly population. So this kind of supplements the problem they're already facing due to the normal aging process. Some of the health conditions are like osteoporosis, bone loss, loss of muscles, which makes it harder for them to move and be physically active. Patients with renal problems may experience changes in renal function. Therefore, older adults may need to be placed on a renal diet that is low in phosphorus, potassium, sodium. So all these things will greatly impact the kind of and quality of nutrition that they can take in. So now we will look at the types of nutritional interventions that we can take to help these patients with health conditions. So one of the first steps to do before coming up with a diet plan or providing a nutritional counseling is to assess the nutritional status of the elderly population. So the mini nutrition assessment short form is a screening method to evaluate the patients for any recent dietary changes, recent lack of appetite, any weight loss, acute disease or psychological stress, any changes to the mobility, any neurophysiological problems, and the changes in weight status. So the MNA, the mini nutrition assessment short form, is the most appropriate nutrition screening tool for use in community dwelling older adults. Though there is an evidence to support the use of other methods, but this is a quick form of assessing the nutritional status of a patient. This is an example of a mini nutrition assessment short form. It comprises of like 6 questions, but they give us quick evaluation of a patient's nutritional status. Like the first one is has the food intake declined over the past 3 months due to poor appetite, digestive problem, chewing or swallowing difficulty. And each question is converted into a scale. Food intake normally decreases as people age, even among healthy older adults. They're not getting the daily recommended intake of fruits and vegetables, whole grains, milk and milk products, and healthy fats. This leads to deficiencies of fibers, minerals, B vitamins. According to a study, 29.1% of hospitalized elderly patients were classified as malnourished. This means that these patients are not meeting their nutritional needs. They are already sick in a hospital, and being malnourished and on a very low calorie diet with all the mineral deficiencies is going to significantly impact their outcome and their recovery time. Um, when you read anorexia, you usually imagine a teenager severely restricting calories, not eating in order to lose weight quickly or stay extremely thin. But anorexia of aging happens in older people because of the physiological changes, the loss of appetite, and multiple medications. We will talk more about the effect of medication on the nutritional status in a little bit. So, basal metabolic rate is the minimum calories required for basic functions at rest. And resting metabolic rate is the number of calories that body burn while at rest, like when you're sleeping. These are calories used to perform the normal functions of preserving life, like breathing, brain activity, circulation, just the fact that you're sitting up. Your muscles need energy to be able to support that. So it has been shown that there is no difference in RMR between young and older physically active men who perform the same amount of exercise or consume the same number of calories. So a young person and an old person who is physically active, similarly physically active and eating the same amount of calories, their RMR is the same. But the BMR changes over the period of your lifetime as you lose the lean body mass. That's the muscle mass. As they age, they also have difficulty to meet their energy needs. So they need to be regularly monitored by weighing them. And like we are all used to being weighed every time we go to the doctors, there's a good reason for doing that. And also we need to consider the fluid intake and output in an elderly patient as the urine production decreases because of some disease states. So you do not want to have the fluid built up in the body. The basal metabolic rate of elderly population decreases with age because of the loss of lean body mass, think muscles, of up to 2 to 5% per decade after the age of 30 years in physically inactive adults. This rate can be slower in patients who are doing or who are more physically active and working out. But it had this loss of lean body mass occurs faster after the age of 75 and is a leading cause of falls and fractures in elderly. So this is a major impact on their quality of life. And sarcopenia and anorexia of aging uh, is extremely concerning for elderly patients, and their nutritional needs is very strongly tied up with these health conditions. Some of the probable causes of sarcopenia are lowered hormone levels, hormones like secretin that are released by stomach, ghrelin that signals the satiation, uh, insulin production is reduced, and which affects the uptake of glucose from blood into tissues and muscles. So they can experience fatigue, tiredness, the decreased ability to turn protein into energy, and also reduced anabolic activity. Anabolic is building up of muscles, the ones they are losing, so it's harder for them to rebuild them. All these things affect their activity level. There's a decline in their activity level, and with reduced activity, the loss of lean body mass is further accelerated. So it's kind of like a cyclical thing. While they lose muscle, reduces their physical activity, which leads to further loss of muscles. So that's why this loss is significant after the age of 75 for adults who are not physically active. Um, this loss of mobility and activity can also lead to inadequate nutritional intake. I would like to look at some of the case studies to see how the health condition. This second case study is a patient with congestive heart failure. It's an 84-year-old female. Patient was admitted with severe uh, edema, fatigue, chest pain. Patient has a BMI of 34.3 and has a mobility issues. Patient is type 2 diabetic with elevated blood glucose of 165, A1C of 9.5. The patient lives alone and receives meals on wheels. So what should be considered for this patient nutrition? So this patient has congestive heart failure. So the first thing to adjust is the fluid intake and sodium intake to maintain safe fluid volumes. Congestive heart failure is the failure of heart muscle to pump enough blood around the body. So if there is more volume, more fluid in the body, the heart has to work harder. So we have to keep the volume within safe range to prevent the excess exertion of heart. Um, her BMI is class 1 obesity, but it also includes the excess fluid retention, which is shown by her edema. So there's excess fluid in her body, so her BMI is not a true representation of her weight. This patient also has type 2 diabetes, so she will need to be on a carb controlled diet with 50% of carb intake, and it should be administered consistently throughout the day to maintain the blood glucose levels. She can benefit from a high fiber diet as it lowers the absorption rate of glucose and keep a more consistent blood glucose level throughout the day. Um, so maintaining fluid volume, regulating sodium is an important part of maintaining fluid volume to help alleviate her symptoms of congestive heart failure. She has fatigue, edema, so reduced sodium would help her with that. And she's getting her food from Meals on Wheels. I volunteer with Meals on Wheels and deliver meals to senior citizens at home, and I've noticed that patients with diabetes and other health conditions, they all get a standard meal, which is concerning maybe she can have it altered according to her needs. She also need regular weigh-ins as she lose water over a period of time, and also to monitor her kidney function. She will need nutritional counseling and educational session to maintain her carbohydrate intake, and also how her fatigue affects her inability to cook or eat healthy. Because when some patients with congestive heart failure also have breathing problems, shortness of breath, fatigue, which can make them lethargic and they don't feel like eating. Even so, it's important to look at all these factors when you're coming up with a nutritional intervention for a patient. For a patient with congestive heart failure, it is important to follow a heart-healthy diet comprising of carbohydrate 50 to 60%, preferably from high-fiber grains like whole wheat bread, whole wheat pasta, to increase the fiber intake. Fiber intake should be around 25 to 30 grams per day. Cholesterol less than 200 milligrams per day. Limit the intake of saturated fats to less than 7% and replace trans fats with monounsaturated and polyunsaturated fatty acids. They need to increase the intake of fruits and vegetables because these are good sources of fibers, micronutrients, vitamins, and also she would benefit from physical activity, limited amount of physical activity to promote her being able to be more independent. So physical activity to burn around 200 kilocalories per day, since she complains of fatigue. And because of congestive heart failure, sometimes patients also experience shortness of breath that can affect their appetite and mealtime. So it would be beneficial for her to eat more frequent meals that are smaller and can keep her, that would help her with her diabetes and have a consistent carbohydrate intake. Her A1C is really high, so she would really benefit from small frequent meals to regulate her blood glucose levels. So these are some of the nutrition interventions for this case study, and I hope I was able to help you better understand the challenges that senior adults face in meeting their nutritional needs. And if you have any questions, I would like to hear from you. And I look forward to making more presentations for the weeks to come. And if you have any topics of interest you'd like to learn more about, please feel free to reach me through your professor. And it was a pleasure making this presentation, and I hope you have a nice rest of the day. Thank you.